and I'm going to introduce and welcome our keynote speaker, Warren Larkin. Hopefully he's there.
Hello, everybody.
Hi, Warren. Nice to see you. So, yeah, Warren is joining us all the way from Chorley in Lancashire, and he's going to present, he's going to speak to the question, how can we move towards becoming a trauma-informed system? Warren, over to you.
Oh, thanks, Joe. Well, listen, thanks so much for inviting me. It's a real honour to get to talk to so many passionate people who are interested in the same thing that I'm interested in. So it's a real treat for me to be here with you. It's not quite the same as being there in person, but you know, we're getting used to this now, aren't we? So, and the good news is I'm getting to start early, which means I've got more time, which is fabulous. So I'm going to start by sharing my screen. This is always the most tense part of the whole episode. Let's have a look. Can you see that? Can I have an old-fashioned thumbs up? Thank you. See, I love it. Right. That's the best part of talking at conferences. You get to have the old-fashioned thumbs up, which is my personal favorite. So I'm going to share my screen with you. And is that still visible? Yeah, perfect. Okay. So how can we move towards becoming a trauma-informed system? Some key concepts and ideas. So I'm going to start by explaining why you should listen to me. Hopefully, the fact that I'm here talking to you means that your hosts have done some due diligence and thought about who they wanted to talk to you. So that's the starting point. But I just wanted to tell you a bit about my experience. So I've been teaching, researching and implementing trauma-informed practices and ideas and approaches for nearly 25 years. I started working in the NHS at the end of the asylum movement. I worked at Prestwich Hospital when it was at the end of its life, really, thankfully. And my job was to help people resettle into the community under the Care in the Community programme, which was an interesting experience. But I guess what I learned is keeping people in hospital for 40, 50, 60 years was not a solution. And actually I saw how that approach to care was unintentionally harmful for people, not only for service users and their families, but also for staff and society. So that's kind of where I started. This is a before and after photograph, by the way, on the left. That's what it looks like when you start working in the NHS. And this is what it looks like by the time you finish. So it's kind of a warning for young people thinking of going into public service. So feel free to use that photograph if you want to scare anybody. So then I worked as a therapist for people with psychosis for the next 20 years, which pretty much means that I was a trauma therapist for 20 years. Everybody I worked with experienced trauma. And then I went on to be involved in academia and to do some work around researching and investigating the links between trauma and well-being, trauma and mental health issues. And I published this book in 2006. And the reason I point that out is in 2006, the idea that trauma might be one of the primary contributors to poor mental health, and in this case, psychosis, was extremely controversial. I'm writing about this in my book at the minute, which is going to be published next year. And there's an interesting story that you'll read about just that demonstrates just how controversial this was. But I won't bore you with the story. For now, all I will say is today, nice guidelines say that people in first episode psychosis services should be asked about trauma, should be assessed for PTSD because it's so common. That's a massive step forward. But in 2006, it was hugely controversial. There was still this dominant idea that brain chemistry and genes were the driver of poor mental health. And today we know that's oversimplistic, and we know that trauma plays a very significant role in mental health issues. And my final episode in the NHS was leading and designing services, one of which was a demonstration site for psychosis in terms of what we can do around psychologically informed approaches and trauma-informed approaches. Then I worked with the Department of Health for a couple of years, advising them on trauma and adversity. And now I work independently. I help organisations understand how trauma affects their staff and their clients. And I help partnerships and communities work towards a future state where prevention is the new normal, where we don't kind of continue to just keep picking up the pieces. We try and move upstream. So that's kind of what I do, and a little bit about why I think I'm the right person to be talking to you. So I've cut a big chunk of this out at the beginning because I'm reliably informed you all know about this stuff. But I think the important thing to say is trauma is hugely prevalent across the world. World Health Organization meta-analysis of 69,000 people across 24 different countries. About 70% of people have at least one traumatic life event, during their adult life or childhood. 30% of people have 4 or more traumatic life events. So it's pretty common, and most people recover naturally. About 20 to 30% of people don't recover naturally and will have ongoing problems and will need some kind of specialist help. But the vast majority of people recover without intervention. And the strongest predictor of recovery in all of these studies was being married. In other words, close social support, which I guess is not a surprise to any of you. We also know that if trauma is not addressed, that it has damaging and long-term consequences for lots of people. This is a slide from my colleague in Manchester, Filippo Veresi. He looked at the highest quality meta-analyses linking childhood trauma and adversity and subsequent mental health problems, and he came up with this list. So there's extremely powerful evidence, and in many cases, proportionate and causal evidence that trauma and childhood adversity leads to all of these mental health problems and all of these difficulties. So it's a massive part of the problems that we're dealing with in society, in the health service, in the social care sector, in the third sector. These things contribute to complex and multiple needs for people. And the origins for a lot of these problems are in unresolved trauma. I'm going to shut the window because my dog's barking, which is really embarrassing, but it was bound to happen. Sorry about that. If you saw, you'd be impressed because she's quite cute, but she's also quite noisy. So you also know about adverse childhood experiences as well. You're well versed in this. All I want to say about this is it's really common. Half the population in England report at least one adversity. 1 in 10 people report 4 or more. And that pattern has been stable over time across countries, across socio-economic groups. No one's immune to this. The patterns have been stable, for over the last 20 years. Lots and lots of household surveys find the same things. And every single study that looks for a dose-response relationship finds it. In other words, people who experience more adversity in childhood have worse physical health, worse mental health, and worse social outcomes at a population level. The other thing I really want to point out is, despite us knowing all of this, it's still really uncommon for people to be asked about adversity and trauma when they come to our services. I'll just let that sink in for a minute. Despite what we've known for the last 20 odd years, it's still incredibly uncommon for someone seeking help to be asked in a consistent way about adversity and trauma. I'm going to come back to that later on. The financial burden. I was on BBC News about this time last year with Norman Lamb talking about the fact that there was no plan for the social and psychological fallout of COVID. And I presented this information. This was Karen Hughes, Mark Bellis' study that helpfully came out the same week. The cost to society, the cost to the exchequer in England and Wales every year is £42.8 billion. Most of that cost is associated with mental health problems, cancer and heart disease. These are the conditions that are directly attributable to the impact of childhood adversity. So the invest to save argument is absolutely immense. It's clearly very obvious that we can't keep doing the same things and expecting a different outcome. We have to actually invest in preventing and mitigating the impact of these experiences on people and society. So there's an economic case for this, but there's also a humanitarian case for this, which hopefully is quite obvious. So why do we need trauma-informed care? Obviously, people are affected by this in the majority. That's the people we look after and help, but also our staff. This is one of those things where we can be pretty confident that most of our staff are affected by it as well. We also know that trauma not only has a profound impact on physical health, mental health and social circumstances, but we also know that actually the traditional approach, which is treating the symptoms, treating the presenting problems, the behavior, that's not working. That doesn't work in the majority of cases. And I'll say a bit more about that. I'll give you an example. So most of the things that we're struggling with, addiction, obesity, risky sexual behavior, gambling, alcohol, smoking, all of these addictions are ways that people use to try and cope. They're all ways that people attempt to self-soothe, to seek comfort. They're all attempts to find relief from distress and pain. but we know they don't work. They don't last. They don't provide lasting relief. The impact is often harmful for that person, for their family, and it's also intergenerational, as you know. So what I've come to conclude over the years is treating the behaviors or symptoms is not a solution when the origins of those problems are social or interpersonal, when they're based in trauma. For example, drug treatment. The highest rate of success for services treating opiate addiction in the UK is 10%. That's the best class-leading outcome for services treating addiction with opiates. That means 90% of people don't successfully withdraw from opiates. And that's because services are commissioned to deal with the harms associated, to do harm reduction, to substitute those substances for safer things. But what services are not commissioned to do most of the time is to deal with the underlying pain. They don't deal with the reason why someone's in pain. They don't deal with the reason why someone is trying to avoid and self-medicate and alleviate that distress. Obesity. There's a lot of great work happening in public health around obesity, and I think that's to be applauded. But we also know that one of the drivers of overeating is an attempt to feel better, is an attempt to deal with underlying discomfort, pain, or distress. And that was the original discovery of the ACEs concept, was when Vincent Felitti found that his patients in his obesity clinic who'd lost loads of weight and changed their lives came back having put the weight on because they disclosed that actually eating was a form of comfort. And most of his patients, if not all of them, had experienced abuse or some kind of household dysfunction. So food was their drug of choice. It made them feel better. And it wasn't about them not knowing about exercise and diet. It was about a need to feel some sense of comfort. We also know that treating the behavior, treating socially unacceptable behaviors by putting people in a hospital for 60 years is not a solution. We know that putting people in prison and sanctioning the behavior, but not equipping them or enabling them to be socially competent, to have more opportunities to deal with their addictions and mental health problems, that isn't a solution either. 50% of people come out of prison and reoffend within a year. Whereas in Scandinavia, in Finland, where they spend huge amounts of time training prison officers, 3 years, and they spend 16 hours a day with prisoners, and they use psychological and social and relational approaches with prisoners. They have a 20% recidivism rate at 2 years. So we have to acknowledge that just treating the problem, behavioral symptom, is not a solution very often when the behavior or the symptom is an adaptation to trauma, is a way of someone coping with pain. So one of the things I think we have to do is help people link their past trauma to the pain, acknowledge that, and then help them find better and safer ways of coping. So the solution is to find out what's happened, to give people the opportunity to make those connections and to give them better sources of resilience, ones that won't harm them or put them in jail. So trauma-informed care, there are lots of definitions. This is my definition. I believe it's the democratization and application of psychological and social science in human service settings. The democratization of science. So that for me means there's only ever going to be a few psychologists and there's only ever going to be a few psychiatrists. What we have to do is put that science in the hands of the wider workforce and in the hands of the people we're trying to help. So we have to apply that knowledge in our settings to have impact. So we have to very much democratize that knowledge. The original concept, the phrase was coined by Roger Harris and Maxine Fallett in 2001, where they published this book using trauma theory to design service systems. They basically said, if we know most people are affected by trauma, then let's use our knowledge of that science to develop our service offer. We have to develop a model that is grounded in an understanding of how trauma affects your neurology, your biology, your psychology, your social development, how it affects attachment, how it affects your kind of identity and all of those things. And by doing that, we can create a service offer that's more sensitive and appropriate to the needs of people using those services. It did lead, I think, for a bit to a misconception that what we're saying is everybody needs trauma-specific intervention. Everyone needs trauma-specific therapies. It's not that. What we're saying is we have to design services with all of that science and knowledge in mind. Some people will And I think there are three pillars to trauma-informed care. One is the service design and the system design. One is the fact that 20 to 30% of people who haven't recovered naturally will need trauma-specific interventions like trauma-focused CBT or EMDR. And those things are scarce. It's not easy to get access to those interventions if you need them. And I think that's a problem. So that's something we have to address. It's not going to go away. It's a complete no-brainer because those therapies produce a huge return on investment, but still people can access them. So we have to sort that out. The other pillar of trauma-informed practice is asking people what happened to them in a sensitive and appropriate way. In California right now, it's legislation. Neddy Burke-Harris, as the Surgeon General, has worked with the Governor, Gavin Newsom, and they've put into place a kind of statewide program of training and incentivization of primary care doctors and pediatricians to ask people what's happened to them when they come in for an appointment. They see that as a public health intervention so they can move upstream. That makes sense to me. However, I don't advocate screening in the UK. I don't think we can do that in an ethical and timely way because I don't think we have the same access to consistent services and interventions all over the country. I think it varies massively. So what I think we should do is, in some services and in some settings, we should routinely ask people. And in some services and in some settings, we should ask people in a targeted way. So I don't think we're dragging people off the street on the basis that they might be at risk to screen them. But I do think where people are seeking our help, we should ask them what's happened. And we should do that carefully and thoughtfully and in a compassionate way. I also think there's a case for asking antenatal visits for health visitors in a primary prevention, in the interest of primary prevention. So the principles you're familiar with, let's not re-traumatize people. A lot of services inadvertently do that, including when I was working in a service that was pioneering CBT for psychosis. I used to invite people for their therapy sessions at the hospital, where many of them had been sectioned and restrained and were pretty scared and traumatized. So that was a really, really bad idea. Didn't realize it at the time, but inadvertently, I probably made it harder for some people to come to their appointments because I was meeting them in a room down the corridor from where they had a really difficult experience. So we do it inadvertently. So we're getting better at understanding that. Obviously, it's about approaching things with a prioritization on safety because people cannot grow, connect, trust, explore, make themselves vulnerable if they don't feel safe. And we have to see that this is a holistic issue. It has to be a biopsychosocial approach that we use, not a biomedical approach. And we also have to educate our staff and the people that we're trying to help about trauma, how it shows up, how it's triggered, how it affects people's behavior and emotional state, and how it affects their relationships and their ability to engage with services. And we also need to equip our staff and our service users with skills to contain, to soothe, to cope better, to ground. We need to give those basic skills out to people so that they can apply them in the day-to-day work, because that can be really powerful. And then finally, we need to absolutely make sure that when people do need access to trauma-focused therapies, that they get it. Because, my view is if you've got psychological problems in England, you are a second-class citizen. You have to wait for 6 months or a year to get the right kind of help on the NHS. Whereas if you break your leg, you're going to get help within a couple of hours. I don't think that's okay. I don't accept that. So we have to acknowledge that. We have to deal with it. So one example I like is Rhode Island Department of Corrections, which is a women's prison network in America. They introduced this idea of universal precautions, so assuming everybody's affected by trauma, and they gave their staff some basic training. So they started doing different things. So rather than just restraining and strip searching somebody, they would talk to somebody in advance about how that might be for them, whether that might be problematic, whether they may have experienced something that might mean that would trigger off an adverse reaction, whether that would mean that they felt threatened, and how that could possibly be done in a way that was acceptable on some level. They also tried to use least restrictive practices and avoided restraint and seclusion where possible, and very similar in mental health services, that there's a movement along those lines. And they taught staff to help the women, ground themselves if they were dissociating or reliving or having intrusive experiences or feeling scared. They noticed their fight or flight response had kicked in, and they, rather than escalating the situation, they would help them regulate. And then they would relate to them and talk and realize that before you can reason, you have to come back into your thinking brain. You have to be in a more regulated place. So those basic interventions that they did in Rhode Island correctional facilities made a huge difference. They were having increasing levels of violence between staff and inmates, and between inmates. Year on year, every year it was getting worse. After they introduced these basic skills and knowledge, they saw a reduction in violence between prisoners and between prisoners and staff for 5 years in a row. And Carol Dwyer, the warden, said that the managers came down and made it clear to staff that they were doing this for them as well as for the prisoners. There was a benefit to everybody. And actually, what they recognized was that the officers absolutely knew the prisoners. They knew the people they were looking after really well. And once they understood that their behavior was an adaptation, it was an adaptation to past trauma, they were then much more willing to see this as a kind of protective mechanism and help that person chill out when something had triggered off that fight or flight response. And Carol Dwyer said they actually understand it better than the psychologists. They don't need clinical language to get it. You just give them the information, give them the tools, and they invent extremely smart solutions. So I think workforce is a really good place to start, of course. I think everybody should have basic awareness and knowledge, a bit like safeguarding. If you're working with people, you should have basic safeguarding knowledge, and that's something we assume. I think this is the same. Most people are affected, so therefore we should have basic knowledge and awareness. Some staff have regular service user contact, and they should have some skills to contain and support people. Other staff have a caseload, they conduct assessments, they have a therapeutic relationship, and I think they need to have a parapsychological role. They need to have a therapeutic role. And I think we need to equip those people with those skills. And a lot of the time we don't do that. And then there are some people whose job it is to be a therapist, and we obviously need to make sure they've got those specialist skills, but we need more people who can do that. That's the bottom line. We need more people who can do that. One way of working out where you're at in terms of moving towards this trauma-informed system is to say, okay, what does that journey look like? Oregon did some great work on this in their mental health services, and they came up with some practice standards. So the Oregon practice standards I really like because they separate this journey into different categories. And, you know, if you're going to do a baseline assessment, you need to know where you're at. You need to know what this journey looks like. You need to know if we're here, how do we get from here to here? And they separate it into different categories. You know, what does the organization think about all of this? Is the commitment from board level through to frontline? How do we hire and induct people into our organization? Do we pick the right people? Do we get them to know what we're about from day one? How do we measure and monitor progress? And we all know that what we measure is what is incentivized. So what we measure is what happens in our organizations. So looking at that through a trauma-informed lens, I think, is incredibly important. And also the way we measure and the way our systems operate, they influence the behavior of our staff. They influence the things that our workers do. Some things will be easy for them to do, and some things will be really challenging for them to do based on the system, the machine that they're a part of and what gets measured. So that is really important. And I think we underestimate that. We measure how many of things. What we don't measure is the quality of things half the time. And then obviously workforce development is crucial, as we've just spoken about, not only making sure workforce have the right knowledge and skills, but making sure we look after people properly, making sure that we provide the right supervision and support, because we really can't afford to lose any more people out of these professions. And then, of course, looking at the environment for our staff and for our clients, looking at whether actually people do feel safe in their job and actually receiving care. We assume these things, but actually let's talk to people and find out what their experience is. And finally, how we deliver care. You know, how is it experienced? How we introduce ourselves to people. You know, their first contact with a service, do people feel that we understand what they need as opposed to what we think we should deliver? And is the experience of care traumatizing, or is it sensitive and acceptable? And has it been co-produced? And has it got the voice of the service user in there? So all of those things we can measure, and I think we should measure them. And I think we should start thinking about where we're at now and where we want to get to. So, you know, you can quantify where you're at. Third part of this, these pillars of trauma-informed practice, asking the right questions. So I've been talking about this for 20 odd years. It's not, the idea is not rocket science, but still it's not standard. What I know without question is that waiting to be told doesn't work. There are too many barriers for someone to unilaterally volunteer their deepest, darkest secrets to you as a professional. There are too many barriers. People who've been interviewed in studies of survivors of abuse in specialist mental health services said they waited between 9 and 16 years of receiving services before they disclosed. That might be 16 years of getting treated with antipsychotic medication. That might be 16 years of having ECT, 16 years of being repeatedly sectioned, because people don't know what the real issues are. People don't know what the underlying problem is. So the symptoms are treated and they get diagnosed with a label, and that's how the system treats them. Reed and Fraser, John Reed and Alan Fraser in Auckland, New Zealand in 1998, same year as the ACE study, observed 100 admissions to their psychiatric hospital. 8% of people volunteered some kind of abuse during their standard assessment. They then asked the next 100 people about whether they'd experienced any kind of physical or sexual abuse throughout their life. 82% of those people said they had. So it was really clear that if we ask people in context, in an appropriate way, they tell us if they're ready to. If we leave it to them, a very, very small percentage of people will find a way of sharing that. The other worry, I think, for commissioners and providers is that if we start asking people what happened to them, we're going to be overwhelmed by demand for specialist resources like psychotherapists and psychologists, and, you know, things that are in short supply. Or they're just going to need more services. Feliti and Ander in 2014 looked at 130, it was actually 135,000 people from Kaiser Permanente, the health plan in San Diego. And that 135,000 people represented 2 years cohort coming into their program. During their health assessment, they gave them an ACEs questionnaire, and they were then given the chance to talk about that ACEs questionnaire with a doctor or a nurse in the context of their health assessment. And in the following year, that group of people used 35% less visits to their GP, and they used 11% less visits to the emergency room, their A&E. So there's a huge reduction in service utilization by simply giving people a chance to acknowledge and talk about their adverse experiences in the context of their health. So actually there's a big reduction in health utilization. And Vincent Feliti later published his views on this, and he said, well, slowly we came to see that asking, initially by an inert mechanism, which was the questionnaire, followed up face-to-face in the exam room, coupled with listening and implicitly accepting that individual who's just shared his or her dark secrets, is a powerful form of doing. So it wasn't a therapy program. It was being heard. It was being listened to. It was being validated. It's somebody saying, thank you for sharing that with me. I believe you. It was really brave of you to trust me. Have you ever told anybody else about what's happened? Have you ever had any help with that? Is it still happening? And if not, is this something that you think still troubles you? Is it something that you think might be relevant to why you're here in our service today? That is incredibly powerful. Yet there's still resistance to that. We also know from 20 odd years of research into social psychology, health psychology, and the science of disclosure, that people who suppress emotion, people who suppress big, important secrets, have impaired immune function, poorer cardiovascular health, have high levels of stress hormones. And it's linked to a whole range of chronic illnesses. I commend this book to you by James Pennybacker. I met him 20 odd years ago at a conference, and he's done some amazing work on how writing and expressing trauma through writing can lead to improvements in immune function, cardiovascular health, stress levels. And studies suggest when you do this kind of work, you see a long-term benefit. People use the GP less. They have less mental health concerns and less stress-related illness. So a few years ago, I developed a program called REACH, Routine Inquiry About Adversity in Childhood. It's a 5-stage model. It starts with readiness, changing systems and processes to make it easy for staff to do this, supporting our staff and workers to understand how to ask, how to contextualize, how to respond sensitively, and how to contain that conversation and agree next steps. There's some follow-up support, and then we also evaluate it, of course. And we've tried and tested this process multiple times over the last 10 years. We've got numerous independent evaluations. The gist of it is, if you don't give workers and practitioners a bit of training and permission, they lack confidence. This feels a bit scary. So once you give them some training, their confidence improves, their knowledge improves, their willingness to have a go at this improves. They do more inquiries. It becomes obvious that it's feasible and acceptable as long as it's planned properly. And it doesn't lead to increased demand. It does lead to better and more cohesive care plans. It does help people make decisions about the sources and origins of their distress and how they want to move forward in life. It can be really motivating. People make really positive changes in their life. And when you talk to parents, like we work with family support services quite a bit, parents reflect on their own experiences of growing up. When you ask them about their adversity, they reflect on their own experiences of growing up. And the next thing they do is they look at the way that they're raising their children. They might be a parent at an antenatal visit, it might be a parent using a family support service. And they go, do you know what? I feel like I had a really crap childhood, and I feel like I'm just kind of repeating what my parents did to me. And I don't think that's what my kids deserve. I think they need better than that. So actually, I'm being honest, but I don't really know how to do it any better. Can you help me? And that is an amazing opportunity to stop this affecting the next generation. Blackpool, better start. We worked with their health visitors recently. The report is beautiful. It made me cry on a Friday night. I was tired, to be fair, but it did make me weep. Really powerful study. I can send it to you if you're interested. But the health visitors asked women at antenatal visit about adversity and whether they wanted any help. It was relevant and acceptable. They interviewed, I think, 29 women. And these are some examples. One woman said, I think it's really important, actually. So many people have experienced trauma when they were little. It makes sense. Another lady said, I think all women should be asked this kind of thing. It makes sense that you can be better supported if somebody knows your background. In terms of intergenerational impact, second lady here said, I've had some quite bad stuff happen when I was younger. It just makes me more determined to make sure mine don't go through what I went through. And the last lady said, it made me think about the type of parents I want to be. And that's nothing like mine. So I commend that to you. I'll send it out if you're interested, but it's really powerful. It just makes you realize that people don't mind being asked. I think it makes sense, and it's an opportunity. In California, what they do after the ACE process, the ACE inquiry process, is they offer a range of these interventions. And if you see this circle, this isn't treatment. Most of this is not treatment. Most of this is resilience building. It's all about what we know from the science that supports well-being. It's all about salutogenesis. It's not about pathogenesis. It's about what supports well-being, the things that help us cope with stress and challenges: sleep, nutrition, physical activity, connectedness, relationships, mental capital, access to nature, mindfulness. So this is a holistic approach. It's not a treatment approach. Most people don't want or need treatment. Some will, and of course we should give them access to that. Public Health Wales looked at 2,500 people who'd experienced 4 or more ACEs. And they tried to work out what's the difference between the people that were struggling with mental health problems and people that weren't. And they found out that actually people who reported higher levels of childhood resilience and adult resilience were half as likely to present with a current mental illness. So even though people have been through the same amount of adversity, the different categories, 4 or more, people who said in childhood they had a trusted adult relationship and regular sports participation were half as likely to have a mental health problem. People who said in adult life they had some financial security and they felt connected to their community or some kind of group were half as likely to have a mental illness. So we know that despite having adversity, people can cope and do really well in life. Adversity and resilience are kind of opposite sides of the scales. Resilience is kind of the antidote, the offset, the mitigating factor. And the more resilience factors people have access to, the less vulnerable they are to the ill effects and the harmful effects of adversity or toxic stress. Which brings us to the next obvious point. There does come a point we have to stop pulling people out of the river. We have to go upstream and find out why they're falling in. So this whole talk of trauma-informed practice leads us on to a logical conclusion, which is prevention. So some of this is about mitigating and intervening earlier and making our services more accessible. Some of it is about preventing, but actually our ambition has to be prevention. Mark Bellis's study in 2014 suggests that if we can prevent ACEs affecting the next generation in England, we could see half as much violence, both in terms of perpetration and victimization, half as many people going to prison, 60% less crack and heroin use, a third less cannabis use, 40% less unintended teenage pregnancies. The prize, the possibility for society is immense. The question is, how do we get there? Well, all of these studies, the Centre for Disease Prevention, the CDC, Centre for Disease Control and Injury Prevention in the US, Public Health Wales, the World Health Organization, there's loads of evidence reviews, right? And they all come to the same conclusions. All of the evidence reviews say, we know that there are programs and interventions that can prevent child abuse, that can prevent child maltreatment and adversity. But in order to realize those things, we need long-term commitment across sectors. That's the evidence. We need long-term commitment across sectors. And I'm talking 10, 20, 30 years, right? So we can realize those preventative aspirations, but we have to come together, commit to the long term. And if you think it took us 50 years to ban smoking in public, after we knew it killed people pretty reliably, 30 years is not a long time. The evidence comes down to four conclusions. First of all, preventative interventions are absolutely effective. They are possible. They're usually the things we disinvest in first when money gets tight. Absolutely, our best investment is in the child and family well-being, the early years, and parenting programs are particularly helpful and return good on investment. We have to get better at detecting and mitigating adversity. So we have to ask people what's happened and we have to give them help sooner. And finally, we have to invest in resilience building programs and opportunities across the life course, because resilience can offset adversity. You can't always fix the past, but you can build a better future. And we have to help people do that. And we know what works, but we have to make it available. So it's all about, the evidence is there. There are pages and pages of appendices in these documents that shows what the evidence is. We just need to make those things a reality. And it'll take long-term cross-sector commitment. One example I'll give you from those studies of primary prevention. The Centers for Disease Control funded a study of P, positive parenting program. And instead of making it targeted, they made it universally available in 3 parts of the world, but this is the South Carolina study. So they didn't target it. They said, anybody who's got kids, here's a P intervention, parenting intervention. It's in the interest of public health. It'll benefit everyone. Loads of different formats, loads of different accessibility. So cut a long story short, at the 2-year point, they saw a 23.5% reduction in child abuse at a time when it was increasing elsewhere. They saw 9.1% reduction in children being removed from home and 10.5% reduction in child maltreatment injuries. This is unheard of, but it's entirely possible because they repeated it in 3 other parts of the world. They also saved $9 for every dollar they spent on this intervention. This is one example. We could talk all day about these examples. It's entirely possible to reduce the impact of adversity on the next generation, to reduce child maltreatment. So this brings us to system change, and it sometimes seems like a bit of a insurmountable problem because we're all busy, we're all under pressure, there's incredible demand on services. COVID's not helped that. Yeah, the forecast is bleak, let's be honest. But there is no perfect time. We can't wait for a perfect time to do this. There is no perfect time. We have, you know, if now's not perfect time, when is it? So we have to try and conceptualize this system change. What does it look like? What do we have to focus on? My experience of this kind of work and the research and all those things have come together into a model that I call the trauma-aware system change model for convenience purposes. And I've used this in lots of different places with lots of different agencies in England, in abroad, looking at how we conceptualize system change and how we bring system partners together to collaborate on this. So in a nutshell, I'm going to go through each of these layers. Normally we would have a workshop, we would have, you know, half a day or a day to work through this with system partners, and we would produce at the end of it a wireframe and a load of work streams, and we'd have a bit of a plan going. But for now, I'm just going to give you a few headlines. I start at the bottom because this is the base of the pyramid. This is where the kind of fundamental foundation of everything is. So the first bit is community. Obviously, trauma-informed approaches, preventative focused thinking brings us to this idea of engagement and co-production. You know, this idea of doing this with our communities, co-producing with our communities, having representation and the voice of our communities and service users and constituents as a part of that. That's not an easy thing to do, of course, but I'm sure you have a lot of expertise in doing it. I'm just saying that's a fundamental part of this whole story. Connection and belonging is another important part of the story. We know that isolation and feeling invisible, you look at the Poverty Truth Commission and other studies, other pieces of work, isolation and invisibility is toxic for human beings. We need connection. We need to feel a sense of belonging. Social support is one of the strongest predictors of health. In the Harvard Grant study that looked at a group of people over 80 years, they found that social relationships was a better predictor of health and happiness over the life course than income, IQ, diet, where you live, any of those things. Social support is fundamentally important to human beings to thrive and to function. And with appropriate social support and connection, we can cope with most things. In fact, social support is one of the strongest predictors of recovery following PTSD. We also know that this is a public health issue, so we have to put this information into the hands of the people. And I always remember Laura Porter from Ace Interfaces off the Resilience film. Her quote was, put this information into the hands of the public and they will invent very wise actions. I absolutely believe that. This is public health information. We have to educate the public about this. We have to give them an informed choice. And my final point on community is people don't buy what you do, they buy why you're doing it. Right, so you can talk to people about this whole program of actions and activities, and you can wave your business plan at them all day, but they won't be interested. Martin Luther King sold the idea of civil rights being a populist movement, something that people could influence, something that people buy into, by talking about his dream, by talking about the fact that he wanted a future where his kids could play with the white kids down the street and they'd be judged by the quality of their character, not by the color of the skin. That is what captivated people's imagination. And before that, he was losing popularity, but that's what got people. So you have to create a vision that people can see and understand, that they want to buy into. So you're creating a movement, and we need the communities and the public, the society around you to be a part of that. Clearly, we talked about workforce already. But I think fundamentally, there needs to be a foundational level of knowledge. People need to have an opinion about this. People need to understand the basic science. People need to have the right knowledge and skills for their job. There needs to be a knowledge and skills framework and appropriate training for each different role. And also, we have to acknowledge that most of the workforce are affected by this stuff. And actually, how accessible is the support that we give to them? You know, a lot of organizations, people say, yeah, there's loads of support in our organization. But then you ask them how good it is. Then you ask them how accessible it is. Then you ask them, do they want to put the hand up and ask for help? And the answer to that is no, most of the time. So actually, trauma-informed supervision, having regular, proactive, restorative, reflective, developmental opportunities for staff and for managers is fundamental to all of this, because if we haven't got well-functioning and healthy people running the services and supporting clients, all of this is for nothing. All of this makes no sense. And that is something we don't do very well. And I will just say, I work with a lot of different organizations on this, and I'll go and talk to all the managers and leaders, and they'll go, yeah, we have really good supervision mechanisms in place. We have really good systems in place. We really look after our staff. I'll go, fabulous. And I go and talk to the staff, and they go, well, yeah, we're meant to have, but actually it doesn't really happen the way that it's meant to happen, and we don't really get support that we're meant to get. So that is a fundamental plank of all of this. We have to look after the people who are looking after the people. We cannot afford to lose any more people from services. The NHS has got 110,000 vacancies. Social care has got 100,000 vacancies. Half the police force in national staff surveys say they're looking for a way out. It's no better in teaching. So I think we have to do that. We also have to train people who have a caseload, who conduct assessments, to ask people what happened to them. That's fundamentally important in all of this. It's an assumption. One of the things I feel strongly about is task sharing. We talked earlier about the democratization and application of psychological and social science. For me, that means there's loads of people out there who signed up for the right reasons, because they want to help people, they want to make a difference. But we don't give them the skills and attributes a lot of the time to convey those therapeutic skills and knowledge, to use that science to make a difference in people's lives. So when I was in first episode psychosis services, I developed a program of training for case managers, mental health nurses, social workers, to use CBT informed techniques in their case management role. We give them training, a manual, consultation time every week, and they started applying psychological and psychosocial knowledge in their day-to-day job. The ACEs cards, they are something I developed as a creative way of working with people, young people or adults who are not particularly verbal or prefer creative methods, to look at the story of what happened, how it affected me, what it's led to in my life, what sources of resilience I might have and which ones I might want to acquire, and then what my hopes and dreams are. So we've got to find ways of sharing these esoteric tasks and skills that are in the hands of a few professionals and making them accessible to a wider range of people. Like mentoring is another good example. We haven't got time to talk about it. I also think commissioning is a really powerful tool. If you're fortunate enough to live in Scotland or Wales, you have a government who've got plans and an opinion and a policy around ACEs and trauma. Unfortunately, in England, central government appears to have no interest or opinion about the psychological and social impacts of COVID or childhood adversity. And most of the kind of serious preventative programs no longer exist. So I think in the absence of that, we have to use the levers that we've got. And whether you agree or disagree with what I've just said, I think we can probably agree that commissioning and service specification really do drive reform in culture and practice. There's loads of examples of that. In Cornwall, I worked with the Community Safety Partnership, who specified routine inquiry, ACE inquiry, as part of their drug and alcohol services, because obviously people who use drugs and alcohol tend to have trauma in their lives. Public health commissioners I'm working with in lots of parts of the country, violence reduction units, they're insisting that staff who work in their programs and their services have some training in trauma-informed practice at those various levels that we talked about earlier. In Alberta in Canada, the state government insists that anybody who works in public service and any provider of public services make sure their staff have done the brain training course, which is like, I think 21 hours of training on child development, adversity, trauma, resilience. And that's part of the Family Wellness Initiative. In Blackpool, Better Start, their health visitor contract has been renegotiated to include additional components. So they don't just do the statutory visits, they have additional capacity and additional resource to do some of that important preventative work. So commissioning can drive practice. I think it's really important, and it's careful how we think about that really does drive behavior and drive practice. Now, when I do workshops, governance, like we say who wants to be in the governance group, and like people start rolling their eyes because it sounds a bit boring, but this is really important and exciting actually. The question is, if this is a long-term cross-sector collaboration, if this is us bringing ourselves around a complicated and big issue that we need to be extremely determined and resilient to achieve, then how are we going to bind together those organizations over the long term? You know, you can get all the CEOs and directors and leaders around the table. What if someone moves the deck chairs? What if some of those people move on? You know, how do we keep those organizations bound together over the long term? So I think that's an important question that you need to wrestle with. I've seen this work really well when after the Future in Mind report was published. I was part of the Children's Mental Health Task Force. I came back to Lancashire. We set up a single integrated children's transformation board to come up with a plan for Future in Mind aspirations and to work out as a system how we're going to realise those aspirations. It was the first time we'd ever had all of the stakeholders around the table at a very senior level. It was, the first year was tumultuous, I think, to say the least. But by the time we got to the second year, there was a high degree of transparency. We had some pooled resources. Everybody knew where the money was being spent. There was a degree of transparency. We coordinated our activities on behalf of the whole. People would test and learn in one part of the county, and they would bring back that learning, and we would, as a collective, apply that to the whole of the county. So there were eight CCGs, and it was the first time we ever had a single consistent specification across the whole of Lancashire for eating disorder services, for example, or a single approach across the whole of Lancashire to children in crisis out of hours. So we tackled some complex and thorny issues that have been around for a very long time by having a co-accountable, single integrated vision of what we were trying to achieve. I mean, it did help, of course, there was some funding attached to all of this. That was a good incentive, but the principle was really powerful. I think board level buy-in is really important if you're going to get something like that to happen. And a strategic partnership board and an accountable leadership group that drive this change is also extremely helpful, because really it's about legacy. Really, it's about sustainability. And you could agree that you're going to have a charter that sets out these agreements between partnerships. You could get the CEOs of these different partnerships and organizations to publicly sign a trauma-informed Brighton Charter, or whatever you want to call it. I was in Macedonia before the pandemic, and the government of North Macedonia publicly signed a charter on child protection safeguarding in front of TV cameras. It was really important that UNICEF got them to sign up in public. So they're just some thoughts about governance. Prevention, of course, has to be the ultimate goal. And if it's not understood by strategic leaders, if the possibilities of prevention are not fully appreciated by, particularly by strategic leaders, but by everyone, it's going to be difficult. So I often do a session on prevention science with strategic partnership boards, with CEOs, with leaders, because we know if we don't get those people on board, we're going to have a limited success. There's going to be a ceiling we keep banging our head on. The other thing that's really helpful is to partner up with a local and international best practice. So there are people all over this country, there are people all over the UK, there are people all over Europe and the US doing amazing things. I think one of the things we forget to do, we keep our heads down and we forget to look outside and go, okay, who's doing this already? Who can we learn from? Who can we partner with? Who can we collaborate with? That's a really helpful approach, and I'm happy to help you with that if you need ideas. I also think school and education is a key part of all of this. Again, let's just drive reform locally. Let's not wait for this to come down from central government. I think the key principle for me is parity of esteem between emotional and intellectual development. The minute the scales are tipped very much on the side of intellectual attainment, and there's massive variation in how well schools are able to attend to the emotional needs of their pupils. Huge variation, huge variation. So there's a really powerful study by Richard Layard. He's the guy who came up with the whole concept of IAPT. He's an economist. He works at London School of Economics, and Lord Richard Layard did a 34-year follow-up study looking at what the life course predictors of adult satisfaction and well-being were. And to cut a very long story short, this life course study found that the strongest predictor of adult life success and satisfaction at the age of 34 was those people's emotional well-being while they were at school. And the worst predictor of adult life success and satisfaction at the age of 34 were those people's intellectual attainment while they were at school. So all this emphasis on exam results, understandable, but actually it's not backed up by the science. The thing that promotes happy, successful people in adult life is a school experience characterized by due diligence and attendance to your emotional well-being. Because if your emotional well-being isn't right, you're not going to learn. You're not going to develop socially. You're not going to reach your potential. That's the bottom line. We know that. So we have to redress that balance. And there's a lot of good work happening around schools and bringing in a more psychologically informed and a more trauma-sensitive approach to education. The other opportunity for me is the antenatal offer. I think very often it's cursory, it's tokenistic. My experience of the antenatal offer when my children were being born was not particularly that helpful. I didn't learn a lot from the diagrams and the plastic baby. I think I would have much more been, there'd been much more value in that experience for me if there were sessions on parenting, if there were sessions on attachment, if there were sessions on the serve and return interaction that goes on between adult carer and child in infancy, if there were sessions on attunement, if we talked about resilience, and also if we gave parents the opportunity to think about their own experiences of growing up and their own adversity. And I also think dads are often left out of the antenatal offer. I think dads are a secondary consideration a lot of the time. And we know that toxic masculinity is directly connected with many of the problems we're facing in society today. And those norms and values have to be challenged. And what better time to challenge those norms and values than when you're thinking about becoming a parent? And we also know that parenting programs give us huge return on investment if they're done with fidelity and if they're done to a high quality. And I think if you're going to experiment with parenting programs, think about offering it universally in a place and see what the return on investment is. That would be an amazing thing to do. And another thing that's made a huge impact on me personally has been seeing the impact of routine ACE inquiry on the work of family support teams, troubled families teams, health visitors, children's centre staff. It's just profound when you see parents think about how they're parenting their children as a result of being asked about their own issues and to do work on themselves as a consequence of it. So I think that's kind of it. I think the last one is my last 2 minutes. We really do have to give people better access to the things that they need to recover and to live good lives. Psychological and psychosocial approaches are very hard to access in a lot of areas. We have to fundamentally realize that unless we ask people what happened to them, they tend not to tell us. So we have to start by asking help-seeking people about their life experiences, about stress, and about what they do to cope. We have to create the conditions for staff to ask routinely, but they have to have the time to listen, and they have to have the confidence to respond sensitively and know when to refer on and know when to actually make an appointment for that person to come and see us again, to talk to us, to make sense of it. because most people don't want an onward referral. Most people want the person that they've trusted with their deepest, darkest secrets to say, thank you, I believe you. And do you need to come back and talk to me some more about that? Most people don't want or need specialist psychotherapy. Most people want a relationship with somebody who shows them compassion. And that requires the staff member to have the time and to have the emotional reserves to be able to offer that person a relationship, some continuity, and some compassion. And we know that if people experience compassion in healthcare and in social care, they tend to recover more quickly and they tend to use less resources. So we need to be honest about what's accessible. We need to be honest about whether staff have got time, whether we incentivize the quality of the relationship. We have to also look at the fact that we don't really use peer support or mentoring as much as we could. There's tons of evidence on mentoring. There's loads of evidence for peer support approaches. We don't use them in the UK. I offered my services to a local organisation when the pandemic started as a psychologist, and they couldn't get their act together to recruit me as a volunteer. I don't think we're that good at. Maybe you are, maybe you're better at that stuff, but certainly the NHS was pretty poor at utilising volunteers. But certainly I think mentoring and peer support is underutilised. And my final point is, it is the relationship that heals. We know that. We need more people in the workforce to have permission, the confidence, and the backup to use their relationships to make a difference. We need more parapsychological workers. And we all know that you don't need to be a therapist to have a therapeutic impact. We know that, don't we? So this is my checklist. I mean, it's a shorthand, but these are the things I think you need to do if you haven't started already. This is based on my work with lots of different partnerships over the past 4 years. First one is get started with a coalition of the willing. Clearly, I think you have that. Agree that a local strategy is required. You might not have it yet, but if you're going to do system change, you need a local strategy that everybody signs up to. Do the baseline assessment that we talked about earlier. Do the scoping, find out what the issues are at place in different organizations and contexts, measure where you're at, and work out what you need to do next based on that. A lot of partnerships forget, I think, focus on the workforce and forget about the managers and leaders. And I think we need to support, develop, offer supervision and help to managers and leaders, because they're the ones that are going to create conditions for change. They're the ones that are going to enable the workforce to do this good work. They're the ones that are going to enable them to use their relationships to make a difference. We can't forget about the managers and leaders. Sometimes they have a really difficult task because they're sandwiched between different competing priorities. So we need to support them. We also need implementation plans that reflect all of the above, and they're going to be different for different organizations, but they're all going to be going in the same direction. They're all going to be working in parallel, and they're all going to be part of this whole vision, this strategy. And then enable and develop the workforce. So, of course, we have to recognize and respond to the impact of trauma in our clients and in the workforce. But we also need to be able to give them those skills that we talked about a minute ago to mitigate and help with the impacts of trauma. We can't just say we're a trauma-informed organization and give them a 2-hour lecture and expect that to be the job done. We have to think about what each different person in each different role needs and what they're capable of doing safely and appropriately. And then finally, we need to look after the people that look after the people. We can't afford to lose any more good people. We know that a lot of staff, a lot of our workforce are running on empty. And I'll leave you with a final thought. Ancient wisdom says it's the connection and the trust and the confidence we have in a person to help us that helps us get better, right? In the past, we used to call them healers or wise people or whatever. But we used to, we would rely on that person starting to understand our subjective world and our relationship and our context. We'd build trust. They'd listen to us. They'd validate us. And we'd go away feeling inspired and things would change. Now, we can call that placebo if you want, but we know placebo works, so that's fine. But we also know that ancient wisdom is backed up by science, because when you look at psychotherapy research, the last 50 years, we found the same thing time after time. It's the quality of the relationship that predicts change in psychosocial interventions. The single most consistent predictor of change in any psychotherapeutic or therapeutic endeavor is the working alliance. It's whether the person you're trying to help rates the relationship with the person that's helping them as positive. And if that happens, they tend to get better. And if it doesn't happen, they tend to either stay the same or get worse. So all of that stuff we just talked about, all of that trauma-informed system change, absolutely I believe in. But unless we get this bit right, unless we look after our staff so that they're able to use their relationship, they're able to form strong therapeutic bonds with people, it'll be worth nothing. And secondly, if we don't look after our people to the point where they've got something left to give emotionally, again, this will all be worth nothing. And I'll leave you with the final thoughts of Irvin Yalom. In his book, Lover's Executioner, he talks about when he would meet new students at university, they'd ask him for his top tips after 50 years of being a psychotherapist. And he said he had 3 tips, 3 lessons. Number 1, it's the relationship that heals. Number 2, it's the relationship that heals. Number 3, it's the relationship that heals. And on that note, I think I'm going to